So, good morning, everyone. I'm Cindy, and I'm with Direction 180, and Direction 180 is a low-threshold, community-based methadone program that opened in 2001, and it was the first of its kind in Atlantic Canada. We opened as a pilot for 30 people, and within the first 6 months, we had over 80 people, and here we are 12 years later. And we've treated or assessed well over 600 people, are currently treating 250 people, have an active waiting list of about 300 people. In terms of an integrated response or the coordination of services for people who access our services, we've been driven by creativity because of the lack of resources since the program's inception. And so, based on that and the issues that people would present with in operating with the determinants of health framework, staff would just, rise to the occasion in efforts to respond to whatever need was most pressing. So over the years, we've conducted about 27 different time-limited projects to kind of increase our ability to provide services or enhance services and, to meet the bottom line. There have been housing initiatives because I do believe housing first for the population that we're working with. In terms of HIV and Hepatitis C, we've had collaborative shared care practice with the infectious disease clinic and the liver clinic to provide treatment on site. And when we've had the resources to do HCV treatment on site, the outcomes have been remarkable. The treatment adherence is much better. People can't always, Muhammad can't always make it to the mountain. You have to bring the mountain to Muhammad. And when we've done that, we've seen incredible results. We work with people to provide them with their other mental health medications and antiretroviral medications and do what we can to help them, achieve an optimum health outcome. In terms of research and what I see doesn't always translate to something the Department of Health or Capital District Health Authority sees as a viable investment. So our partnership with Dalhousie and Aaron and the academia folk helps us to take what we see and translate that and express it in a way that somebody listens to us. Currently, we have a couple of research projects underway, and one of which is the methadone, the realist synthesis review. And so that's looking at a whole bunch of articles and looking at interventions that support people. And the impetus came kind of from that, conversations with Lois and Diane about people on methadone who can't access recovery treatment facilities if they're on methadone. They're only for abstinence. Huge challenges. Another one is looking at methadone treatment adherence and HIV antiretroviral treatment adherence. And, you and I, or most people operate with 9 to 5. When you're using drugs, you don't have 9 to 5. And so we might think that our program is flexible in offering methadone between the hours of 8:30 and 12, but if you've been on a crack run for 7 days, it's pretty hard to make it in time to get your methadone or continue to take your HIV meds. So looking at some of the barriers and asking folk, what would work? How can we better improve this? Other, huge challenges, I think about the question earlier today posed, are Atlantic Canadians more at risk of HIV and Hepatitis C? Absolutely. The resources, are so grim in Atlantic Canada. And our numbers, although our numbers are increasing, if you look at the sheet that was handed out today, it doesn't seem to matter. It doesn't seem to matter that, you know, there's best practice, there's evidence out there that supports primary interventions and needle exchange programs and methadone maintenance treatment, safer, you know, crack use kits, all of those things. However, we seem to, there's still a blind eye, and, you know, I think it rests a lot with our public perception and the stigma. And some of you may be privy to what we endured in the fall of this year. Direction 180 and efforts to expand access to methadone treatment had tried to rent a facility whereby we could provide a waitlist management program for people who had been waiting. Dolores mentioned weeks and months. It's actually people waiting years for treatment, and we couldn't get a place. Nobody would rent to us. So we, with a pharmacist, bought a property, and when the community learned who and what we were, they objected strongly. And within a few days, they raised $100,000 for us to go away. Fortunately, Diane Bailey and I had, following a transit strike last year in February, had gone down to Baltimore to research mobile methadone maintenance treatment, because we had an imposed pilot during the transit strike and learned that it was an effective way to expand access and to improve retention. And so during that trip, and I can't speak enough to the benefit of face-to-face meetings. I'm not a teleconference girl. There's nothing better than a face-to-face meeting. During that trip, we met people and had the opportunity to meet. And because of that trip, in July, we were contacted and we were offered a fully equipped unit for $25,000. And I was fortunate enough to charm a pharmacist to give us the money, and we bought it. So that unit rolled out. The good news is I'm not all grim and despair, but the unit rolled out in January 15th. And thus far, we have admitted 54 people. We're providing mobile services in Fairview. We still have some opposition in the community about where it is we're parked, and Dartmouth. And we're looking to secure a parking spot in Halifax. We're also, with the leadership of Jackie Gahagan and in partnership with Mosh and some other great people in the room, looking at implementing a pilot rapid point of care testing on the mobile, and in partnership with Mosh, so that's pretty exciting stuff. And I forgot to mention that the name of the unit, the driving force, the name of the Direction 180 mobile is called the Bailey Bus, in honor of Diane Bailey. And the Bailey stands for Broadening Access, Improving Lives, and Engaging You. With that, I'm happy to be here. Thanks.
Might we mention that Diane drove that bus? Yes, all the way from